Hi and welcome to Healthy Living. I'm Debbie Lyons here today with Kelly Presnell, Director of Marketing and PR here at Hilton Head Hospital. We have a fantastic show.
Yes, Dr. Amanda Parks, she's infectious disease. She's going to be on the show. She started here a number of years ago, but you know, we've had the opportunity today for her to introduce herself, what infectious disease is, some things that we're hearing out in the community and just general media, that we all might have questions about for infectious diseases.
Couldn't be more perfect timing. I'm really excited to talk with her.
Yeah.
The vision for Hilton Head Spine Center is very clear. It's to provide world-class spine care to our patients.
Physical therapists were there. They were there holding you up. It's nice.
I just love working with all of these patients and their families and getting to know them and helping them on their journey.
My life is definitely better, and I'm glad that I came here at Hilton Head Hospital.
No one likes to wait, especially in any ER waiting room. I mean, when I'm sick or my family has a medical issue, I don't feel like waiting around with a lot of other people. Not to mention they're sick too. Honey. And my family does not wait patiently. You can imagine how uncomfortable and how long it can seem. But then I found out it doesn't have to be that way. I can check in online and wait anywhere I want. What's not to love?
It's the smarter way to ER at Hilton Head Hospital.
Hi and welcome to Healthy Living. We are here today with Dr. Amanda Parks. I am so excited to talk to her. She is a physician of internal medicine with a subspecialty in kind of what you do now, infectious diseases, which I think is absolutely fascinating in light of the time that we live in. I know just recently with the measles outbreak, it was a flashback. I was born in 1953, and I remember going to school, and that was considered one of the most communicable diseases as a child. Talk to us a little bit, if you will, about what an infectious disease doc really does. What is your role?
So the role that I serve primarily is that I consult at the hospital. So I'm an internal medicine subspecialist, so I run a consultative service. So for the internal medicine or surgery service, if they have any infectious disease questions, then they'll consult me to come evaluate the case, basically.
Let me ask you a bit about your background, where you went to school and how you kind of arrived at the notion that studying and practicing in infectious diseases is something that called to you.
People ask me a lot why infectious diseases, and I think it's just the neatest subspecialty ever. If you are interested at all in history, wars have been won and lost based around the presence or absence of bacteria. It affects our lives every day. So I love infectious diseases. I think it's really interesting.
She's really fascinating to talk to. I know that you had a triple major in school. I have to show that off because Italian, literature, and biology, that's pretty impressive.
Yeah.
So let's talk about kind of basics. When we talk about infectious diseases, what are we really talking about?
So in essence, in an everyday setting, we're talking about complicated pneumonias, meningitis, endocarditis or heart infections, post-surgical wound infections, infected joints, infected total knees or hips, very resistant organisms. So you've probably read about that in the paper.
Yes.
The emergence of resistant organisms. And another thing that we do at this hospital is we are very strong in our stewardship initiative.
And let's talk about that, because I know when you and I were getting together and kind of chatting about the way that we wanted the program to be structured, and one of the things that you were really excited to talk about is is really what that stewardship looks like and how it emerged.
So in September of 2014 of last year, you probably remember that the president issued a statement from the White House saying that he considered emerging antimicrobial resistance to be a threat to national economy and health. And so part of that statement out of the White House basically said that they were going to make stewardship programs mandatory at hospitals, and we already have that here.
Pretty impressive. And what does that look like?
Basically what we do is that we're stewards of our antibiotics. We have a very limited number of antimicrobials, and very few antimicrobials are now being developed. So what we have to use very judiciously. So what we do with stewardship is we review the antibiotics that are used in the hospital every day and try to minimize those antibiotics that are used. And in so doing, we delay the development, hopefully, of incredibly resistant bacteria.
What makes a bacteria resistant? How does that happen? Is it overuse? Is it improper use? Is it all the things that we've all done with our antibiotics we shouldn't do? Take it for 8 days instead of 14?
Yeah, exactly. Yeah. So by and large, the emergence of resistant organisms, they come about with being exposed to antibiotics over and over again.
Okay.
And so basically you select for a population of bacteria that has a gene that renders the bacteria immune to the antibiotics. And the bacteria can swap genes, unfortunately. And so you find these populations of bacteria that none of our antibiotics can treat. And so what we're trying to do with stewardship is delay the evolution of those resistant microorganisms.
Practically speaking, what does that even look like? It just...
So one thing that we do is we review all the antibiotics that are used in the hospital every day, and we try to minimize any antibiotics that don't need to be used.
Okay.
Another way around doing that also is bringing rapid diagnostics to our hospital. So if you can diagnose the difference between a bacterial infection and a viral infection sooner, you can take away the antibiotics. And in essence, avoid using them unnecessarily. See what I'm saying?
I do. What is the difference between bacterial and viral?
So that's a great question. So common bacterial infections would be like pneumococcal pneumonia, or you've probably read about MRSA or staph infections. Those are serious bacterial infections. You've probably read about the resistant bacteria from the endoscopes, the CREs. Those are incredibly resistant bacteria, right? Antibiotics kill bacteria.
Period. Okay.
Antibiotics do not kill viruses. So if you have a viral infection, like the flu, for example,
24-hour tummy bug,
measles, or whatever, we don't have antibiotics to fix those things, right? We have a few antivirals, but there's no reason to treat a virus with an antibiotic.
You know, I guess, again, being a patient or a consumer, when I think of that, I think of the difference between a cold and the flu, or a cold and strep throat.
Right, right. So a cold is generally a virus.
Okay.
The flu is a virus.
Okay.
Strep throat, definitely a bacteria, right?
And do you culture to see the difference, or what? You talked about being able to rapidly diagnose.
Yeah. Oh, yes. Rapid diagnostics.
See, we listen to you.
I'm so glad that somebody listens to me. So rapid diagnostics are sort of the wave of the future, and we do have those in different incarnations right now. The same technology you're probably aware with when you watch TV shows that have forensics,
right,
like
CSI
detective,
and all that,
CSI and all that stuff, right? So when they talk about finding DNA, it's the same technology, right?
Okay.
And so what we do right now, the gold standard in infectious diseases, is based on methodology from the 1800s. So we grow bacteria, literally put it on a petri dish, put it in an incubator, and every day we check on it, right?
Swab, check.
It takes days, days to get a result, maybe days that we're treating you incorrectly. So with the advent of rapid diagnostics, with molecular diagnostics, we can come up with a more precise answer on the time scale of like an hour.
Oh my gosh.
So you would have an immediate result, say, when you're in the ER. So the difference between rapid diagnostics and our traditional diagnostics could be the time. It could be the difference between being admitted or not being admitted, right? If we know that you don't have a severe bacterial infection, you have a viral infection, we could maybe do an overnight stay as opposed to a 5-day stay in the hospital, which from a patient's perspective would be much better, right?
One of the things that you and I talked about that I thought was fascinating is that you talked about having food or animal protein and antibiotics that we, and just using our hospitals, doing an excellent, if really superior job of managing our antibiotics, but out in the world, we're getting antibiotics we need to pay attention to.
Right.
Can you share a little bit about that with us?
So that's when you and I were discussing ways to minimize your exposure to antibiotics and resistant organisms. So one of those things is minimizing the amount of antibiotics that you take, right? To only take antibiotics when you really need them. When you look at all of that antimicrobial pressure, if you have a pie chart of the contributing factors to emerging resistance, to resistant bacteria, a little chunk of the chart, about 30%, is what we prescribe humans. So the antibiotics that maybe we inappropriately prescribe humans for viral infections. 70% of the chart is antibiotics that are used unjudiciously in agriculture, right? And so what that ends up coming through to the consumer is meats that have been infused with, say, hormones and tons of antibiotics unnecessarily. So that antimicrobial pressure in the agricultural sector also drives the emergence of resistant organisms.
Is it a prophylactic treatment? Is it a prophylactic treatment by farmers to ensure that their herds don't die or whatever?
Exactly. Yep.
So how does a person become a good consumer and not?
Well, I mean, I'll tell you, actually at this hospital, the meat that they serve in the cafeteria is antibiotic and hormone free. So part of it is being an empowered consumer and saying, you know, where do you get your meat? For example.
Right. Well, I mean, just even listening to you now, when I go to buy my meat, I'm sure it's poultry too.
Oh yeah, definitely.
I will ask, you know, is this, and I guess they have to say that they do it, right? I mean, are there?
Oh yeah. I mean, the grocery stores that I shop at are almost completely dictated by who has the best supply of antibiotic-free meat.
Oh, it's fascinating. Again, we're here today with Dr. Amanda Parks. We're talking about infectious diseases. We're going to take a break here on Healthy Living, and when we come back, we're going to talk about measles, vaccinations, being an aging adult, and if we do need vaccinations. So stay with us. We'll be right back.
Pain. It can be different things for different people. A shoulder that takes you out of the game. A knee that stops you in your tracks. Ready to return to a better you? Hilton Head Hospital is here, right in the Lowcountry, to help heal what hurts. From diagnosis to treatment to full recovery, our fellowship-trained orthopedic specialists are committed to getting you back to your best. Hilton Head Hospital. Extraordinary care right here at home.
Hilton Head Regional Medical Center is located at 25 Hospital Center Boulevard. When traveling east on William Hilton Parkway, make a left-hand turn on Beach City Road, and the next left, Hospital Center Boulevard will be located just past the Hilton Head Library.
Coastal Carolina Hospital is located on US 278 at Exit 8 on I-95. Telephone is 843-784-8000. On the web, www.coastalhospital.com.
Pain. It can be different things for different people. A shoulder that takes you out of the game. A knee that stops you in your tracks. Ready to return to a better you? Hilton Head Hospital is here, right in the Lowcountry, to help heal what hurts. From diagnosis to treatment to full recovery, our fellowship-trained orthopedic specialists are committed to getting you back to your best. Hilton Head Hospital. Extraordinary care right here at home.
We are back here on Healthy Living. We're here today with Dr. Amanda Parks, and we're talking about infectious diseases. It's absolutely fascinating. I think intimidating to some people, but you're really doing a good job of sharing with us what is real in a language I think that we can understand. What we were talking about during the break, and we promised everyone we talk about, is I've been reading about measles for the past month, Ebola before that, and again, because I'm older, I hear about shingles all the time. I was just recently asked if I had a tetanus vaccination. Can we touch on all of those kinds of things more from an adult population than a kid?
Sure. So measles is really interesting because, probably 99% of the physicians in this hospital have never actually seen a measles case. We can answer all the test questions, we could probably pick it out.
Right.
But, we started a measles vaccination campaign in this country in 1963.
Oh, wow.
And so we've been wildly successful with that vaccination campaign. But
I was born in '53, and you said that was considered
natural immunity.
Okay.
So anybody born before 1957 is considered to be naturally immune. So measles is a perfect example of how, as a community, we forget those types of diseases if we don't see them. Well, before 1963, we had 3 to 4 million cases of measles a year. Like 50,000 annual hospitalizations and 4,000 cases of encephalitis, which is a brain infection that can result in deafness or mental retardation.
Let me ask
so
you
people
about,
forget about that part of measles.
Because I still think we talk about measles, and most of us can't. So what? So you get a rash. I mean, what are the repercussions of something like a measles or a mumps or a polio or?
Right. So in particular, again with regard to measles, you can have when you look at those stats in the pre-vaccination era, 50,000 hospitalizations a year for measles, and then 4,000 of those having life-altering encephalitis cases.
Oh, wow.
So those are real numbers. And the thing is, the other thing to touch on, particularly for an older population, and from a public health perspective, is something called herd immunity, right? A virus or bacteria is only as dangerous as its transmissibility rate and also the number of susceptible hosts in a population. If you don't have enough susceptible hosts in the population, it'll never spread. It can't propagate, right? And so that's what you call herd immunity, is when you have so many people that are vaccinated, it can't physically spread among the unvaccinated people, right? They're too far spaced apart.
That makes sense.
Yeah, so it's important in very young people and very old people who could have potentially fatal outcomes if they were infected with measles. So,
what about re-immunization? Is there such a thing?
So at present, you're considered to be lifelong. You're considered to be immunized for your life if you've had two doses.
Okay. Is that with many vaccinations?
And the thing is, as we move forward in time, we're starting to do more evaluations. We do evaluations of certain age groups, and we check titers to see if you have waning immunity over time. And we know that our immune system wanes over time. And so for some things, we know that we need boosters, like tetanus. You need a booster every 10 years, right? Right now,
is that true every 10 years?
Yep.
Oops.
Yep. It's true.
Whoops.
So right now we don't know about boosters for these other diseases. You have to do a full evaluation on a population-based study to say for sure.
What about HIV, things like that?
So there's no vaccine for HIV yet.
Okay.
However, they've been working on one for a while. New and promising results in that regard. For all of my HIV patients, for my new diagnosis HIV patients, I basically tell those people it's like being diagnosed with diabetes now.
So it's chronic disease.
Yeah, it's a chronic disease. Just like diabetes, if you take your medicine every day, you'll, for the most part, lead a long, normal, healthy life.
I've talked to 3 or 4 people recently, really 40 and above, who have had shingles. Is there a vaccination for that?
Yes.
I hear about it, but who needs to get that, and what is that bacteria?
It's a virus.
It's a virus.
Yeah, so
wait, I vaccinate for a virus. I give an antibiotic for a bacteria?
Okay, you're confusing 2 concepts,
okay,
right?
good.
Which is fine. So one is immunization or vaccination, and so I give you that. I expose you to that pathogen in a live or an attenuated form, and so we give you immunity, right? So you develop an immunity, right? The antibiotics and the antivirals, we treat an infection. With vaccinations and immunizations, we're preventing an infection.
So we like prevention medicine.
Yes.
Which makes a lot of sense.
I'm an infectious disease doctor. If you ask me how I feel about vaccines or any vaccine preventable illnesses, I will always vote for a vaccine.
Wow, that makes sense. All right, so go back to the shingles vaccine.
So for
Who needs it and why? And what is shingles?
So shingles is a virus. If you've had chickenpox, it's one of those viruses that remains dormant in your body. You got over chickenpox, and maybe you don't even remember having chickenpox. 99% of our population has had it, has immunity to it, and it remains dormant in a part of your spinal cord called the DRG. So it's back there, and as you get older and your immune system wanes, or if you have an extremely stressful event in your life, that latent virus can reactivate and become active again. And it comes out in a certain distribution on your skin and a characteristic rash, and we call it shingles.
Is there an area that it's more prevalent? Does it come out on?
It's usually a truncal rash,
Okay.
and it's called a dermatomal distribution. So it has to do with the nerve roots that it reactivates along. So it comes out in a patch of these vesicles, these little painful blisters, basically.
Oh, so it's painful.
It's very painful. It's very painful.
It's
yeah.
painful, which means we should get immunized for
So,
it.
and even if you've had shingles,
Okay.
the recommendation is to get the shingles vaccine.
Is it really?
Yeah, and so the reason why is that if you were to have shingles again, the studies indicate that the pain that you have after shingles is much less if you have a vaccination.
All right, so we talked about shingles, talked about the measles. What about pneumonia?
Pneumonia is really interesting. We actually had a very serious case in a 33-year-old at our hospital of pneumonia, and people kept saying, "What's wrong? You know, what is this?" This is classic pneumonia, and the thing is, it's another one of those diseases that you forget what classic pneumonia looks like. So the news with pneumonia vaccines in adults is now we have a second pneumonia vaccine, right? So for anybody over the age of 65 or with certain medical comorbidities that lowers your immune system, the advice is to get your pneumonia vaccine, and it's actually 2 that need to be given at least 6 months apart.
Can I ask you an even more basic question? What is pneumonia, and why is it so lethal, or why is it of such concern?
So the pneumonia that we're talking about is a bacterial pneumonia
Caused by?
Streptococcus pneumoniae.
Okay.
Right. So you brought up strep throat, which is a different strep. The whole genus of strep is really fascinating. But classic pneumonia is Streptococcus pneumoniae.
And it is caused from?
So it's a bacteria. It's a highly transmissible. It's a communicable bacteria.
Okay, so it's not is it a secondary infection, just something else? In other words,
It can be. It can be. Sometimes what you see is a viral respiratory infection, particularly, let's say, in somebody that already has a lowered immune system.
Okay.
If you're on chemotherapy, if you're a transplant, if you have HIV, diabetes, if you're older. So if your immune system is lower at all, and then let's say you get one of the numerous respiratory viruses that are circulating right now.
Okay. Yes.
That may pave the way for a bacterial superinfection. So sometimes you get a secondary bacterial infection after those things.
And and again, you bring up the word superinfection or superbug. For you, on a day-to-day basis, what are some of the things that you do at the hospital? You touched on it, initially, but more in depth. You spend a lot of time if someone suspects an infection after surgery, or
Yeah. So one of the things that I do is work. Part of our infection control efforts at this hospital is to prevent surgical wound infections. So at this hospital, we're actually very progressive in trying to prevent those, right? And luckily, our surgeons are very helpful, and they participate a great deal with regard to these efforts for preventing post-surgical site infections. So a typical day that I do here, so I work on infection control, where we try to prevent infections and prevent the emergence of incredibly resistant organisms. Every day I round with the pharmacist on our stewardship rounds, where we evaluate the antibiotics that we use. I round on our inpatient infectious disease service, anybody who's in the hospital that I've been consulted on, and then I see patients in my office. So that's kind of what my day looks like.
So when you actually see a patient, are you just following up with that they're getting the appropriate treatment, or if they're having secondary infections? All of the above.
All of that, yeah.
So it's always fun for us to have takeaways. And I've gotten a lot of really specific takeaways. And I think more than anything, it's been tetanus, shingles, get vaccinated, pay attention, prevent, and the herd effect will stay. Does that make sense?
Yes, yes.
It's really
yes,
interesting.
yes.
You've been great. I really appreciate you taking time out of your day today. We thank all of you for joining this week on Healthy Living.